Okay, looks like
All
we're
right
back.
then. I can't hear anything.
Well, good morning. It's a pleasure to have the opportunity to speak with you about sleep disorders in multiple system atrophy. I'm a neurologist who specializes in sleep medicine, and I've been interested in the relationship between sleep and multiple system atrophy for probably about 25 years. Sleep disorders are an intrinsic part of MSA, and the good news is that we can treat most of them. And in so doing, we can improve quality of life. And that good news is what's going to be my theme today. So I have no disclosures, no conflict of interest. What I'm going to be talking with you today is two groups of sleep disorders. The first are disorders of movement, excessive movement during the night. And we're going to spend most of the time talking about REM sleep behavior disorder, but I will mention in the end periodic movements of sleep as well. And then in the second part of this talk, I'm going to move over to the other characteristic sleep disturbances in MSA, which are disorders of breathing or respiration. And again, we're going to spend most of the time talking about nocturnal stridor, but I will also mention sleep apnea and hyperventilation. So let's start off with REM sleep behavior disorder. And in order to understand REM sleep behavior disorder, I'm going to take a step or two back and talk a little bit about normal sleep and REM sleep. So a normal night's sleep consists of between 4 and 6 cycles, each approximately 90 minutes. And in each cycle, a relatively longer period of non-rapid eye movement or non-REM sleep is followed by a relatively shorter period of REM or rapid eye movement sleep. If we take a night as a whole, about 1/4 of the night is spent in REM sleep, and about 3/4 of the night is spent in non-REM sleep. Non-REM sleep actually has 3 stages of increasing depth, N1, N2, and N3, not important for our topic today. Now, if we take a night as a whole, here's a schematic drawing of just such a night, and let me take you through it. The subject falls asleep and enters non-REM sleep, going through increasing depth down to N3, and then about an hour and a half after you fall asleep, you go into your first period of REM sleep, and then back into non-REM sleep and the second period, and on through the night. Now you will note that the periods of REM sleep shown by this dark black boxes increase as we go through the later cycles of the night. So there's more REM sleep in the second half of the night than the first, which is one of the reasons why one sometimes remembers one's dreams, because there's an excellent chance one's going to wake up after here in this particular person 7.5 hours in the middle of REM sleep. Also, that suggests that disorders of REM sleep, such as REM sleep behavior disorder, are more common in the second half of the night than the first. So what does REM sleep consist of? Well, REM, of course, stands for rapid eye movement, and the most characteristic feature of REM sleep is that the eyes move, mainly side to side, sometimes up and down, and these are associated with dreaming. And these are the vivid, hallucinatory, multicolor, emotionally charged dreams that we all recognize. They occur during REM sleep, and it's probable that the dreamer is looking at their dreams when they move their eyes. The other characteristic feature, and very important for our discussion today of REM sleep, is that our muscles are paralyzed in REM sleep. Now, obviously not all our muscles. The muscles that control the eyes must be working to give us the rapid eye movements, and the diaphragm, the big muscle under the chest which keeps one breathing, obviously continues to work during REM sleep, but most of the muscles, the face, arms and legs, are paralyzed. And when you think about it, that's a good thing, because otherwise, every time one dreamt one was being chased by a tiger, we would possibly jump out of bed and run down the hall, and that certainly wouldn't be healthy. Superimposed on this paralysis of muscles are tiny little twitches of the muscles, almost as if they're trying to work but can't. So this video is that of a dog, a normal dog who is sleeping during sleep. Who's sleeping, you may hear a little snoring, but I want you to concentrate, it's very small here, on the dog's eyes, and we should be able to see the eye movements. Let's see if this works. There's the movements there. You can see some movements of the eye. Concentrate on the light, which is really the pupil there, reflecting light, seeing how it's moving from side to side. There we go. Those are nice rapid eye movements. Okay, well, we are like dogs in this way. We have the same rapid eye movements, the same REM sleep. So with that introduction, let's talk about REM sleep behavior disorder. And this illness is characterized by a loss of the muscle paralysis of REM sleep. In other words, one can act out one's dreams. As a result, patients who have REM sleep behavior disorder will talk, shout, sometimes scream in their sleep. They'll flail their arms. They'll sometimes punch. They'll kick. They may fall out of bed. This is potentially a dangerous condition. Most bed partners of people with REM sleep behavior disorder will describe that they've been at least punched, sometimes with bruises. We've had occasional bed partners who've had black eyes from punching into the face. I had one patient who regrettably knocked out his wife's teeth during one of these episodes. In addition, the patient can injure themselves as well, just by flailing out the arms against the wall or the bedside table can cause bruises and lacerations of the skin. If you fall out of bed, you can have more serious injuries, unusual, but we have had some patients with fractures of bones and a couple over the years with blood clots on the brain from hitting their head against a radiator or something like that, though that's exceptionally rare. In addition, the dreams change. Most people with RBD will describe defending themselves against attacks, either by people or by animals. It's very, very rare for somebody with RBD to become the aggressor in the dream and to be violent themselves, almost never. But some patients do occasionally have sports dreams or adventure dreams, but most of them are defense against attack, either themselves or their loved ones in the dream are being attacked and they're defending that person. Now, this is 30 seconds of a sleep study. So here's the beginning of the 30 seconds, here's the end. And on the top two channels, we're recording the rapid eye movements. And here they are. You can see how the tracing goes up and down here. Those are rapid eye movements. The next three record the brain waves, the EEG, but I want to concentrate on the lower three here, which is recording muscle activity with electrodes on the skin over the chin muscles, leg muscles, and arm muscles. And every time you see all this black activity here, that's movement. And this is very much excessive movement. People in REM sleep may get those tiny little twitches I mentioned, but nothing like this. This is a patient with REM sleep behavior disorder. Now, why is this associated with MSA? Why are we even talking about it today? Here we have a section through the brain, and it's as if we took an axe and went down the center of the head, as I'm showing you on my face here, and then looked in from the side. So here is the front of the brain. Here's the back of the brain. This is the cerebellum, the big brain organ at the back that controls balance. But we need to concentrate on the structure here, which is the brain stem. The brain stem is a rather narrow structure which connects the whole upper part of the brain here down to the spinal cord, which is that big cluster of nerves running down one's back to the sending off nerves to the arms and legs. And the brain stem is a passageway by which all the nervous impulses from our cortex can be transmitted down to our arms and legs, and conversely, any sensations we feel in the arms and legs can be transmitted up to the brain. So obviously a vital part, but there's more to it than that. In the brainstem are some very vital nerve centers, and the first of those are the ones that control REM sleep. This part of the brainstem is called the pons. This is the medulla, and in this little part, yellow dot here of the pons, that's where sleep is controlled. In addition, the pons and the medulla have the centers which control breathing. Now, as you probably know, MSA has a tendency to affect the nerve cells in the brainstem, especially the pons and the medulla. So it's not surprising that we'll get damage to the REM centers and to breathing centers. And that's why all these disorders are so common in MSA, because this is the part of the brain which is most prone to dysfunction in multiple system atrophy. So how many MSA patients will get RBD? And the answer is different studies have shown different numbers, but it's probably between 60 and 90% of patients. And this may occur at any stage of the disorder. So there are certain patients in which RBD is the first symptom of MSA, coming sometimes years before anything else develops. But in other patients, RBD may occur at the same time as early symptoms of MSA. There may already be autonomic symptoms, lightheadedness, standing, bladder problems, or some movement disorders, and RBD starts at that time. And in still other patients, RBD may develop much later in the disease course. Now, let's consider first this group of patients in which RBD is the first symptom of something. So we have a patient who comes to see me who is complaining of acting out dreams. But when I take a history and examine the patient, there is nothing wrong neurologically. Otherwise, it's just a history of acting out dreams. What is likely to happen to that patient? Well, if you follow those patients, and here's a study of 1,280 such patients, after 12 years, 73% of those patients will have developed a neurologic disease. And the most likely diseases they will develop are actually not MSA. They are the much more common Parkinson disease or dementia with Lewy bodies related to Parkinson. So the majority of people who start on this track will develop one of those two disorders, but a minority will develop MSA. It's a minority because MSA is less common than these two very common disorders. Early on, it is not possible to say which of these disorders the patient will develop, or any of them. Remember, even by 12 years, only 73% have developed them. But as the disorder progresses and other symptoms develop, it becomes easier and easier to determine whether which of these three disorders they are developing. Now, the bad news is that regrettably at the moment, we have no medications at all available which can reduce the risk of developing these disorders when we know the patient has RBD. And that is, of course, the goal of much research at the moment, to find medications which we could intervene with early in the disorder once RBD just starts and prevent these developing. And I've little doubt with time we will develop that capability. So let's talk about the treatment of RBD. We have a patient now who has REM sleep behavior disorder with MSA or maybe without. What do we do? Well, first I sit and obviously discuss the diagnosis with the patient. If the person doesn't have a neurologic disease at that point, I do generally tell them what to expect. I ask them first, I say there's a possible relationship to developing a neurologic disease with time. Do you want to hear about it? And the majority of patients will say, yes, they do. And then I talk to them very frankly about what I've just talked to you about. And I do that because we believe in patient autonomy. People have the right to know what is happening to their brain and to their body. I do it also because I know they're going to go to the internet and read it up and probably get wrong information. I'd rather give correct information. And the third reason has to do with bucket lists. If we have somebody who's, say, 64 years old and develops RBD, I will sit down and talk to them a little bit about what are their goals for the future. Maybe they say, I'm going to work until I'm 70, then I'm going to retire, and then I want to travel all over the country. And I may gently say to them, you know, if you can afford it financially, maybe you want to do it a little earlier. And just think about the same goals, the same dreams, but doing them perhaps a little earlier than you might otherwise have done it. We then move on to talk about bedroom safety. Move the table away from the bed or perhaps covered with a cushion, depending what behaviors they've experienced up till then. Some people, I even recommend a foam mattress on the floor, cushions on the floor, if they've had a tendency to throw themselves out of bed, that's not common. Sometimes the bed partner chooses to move to another bed, and that can certainly be done. In terms of, if there are any guns in the bedroom, I strongly recommend they be removed or at least left without any ammunition. As far as medication goes, the first line of treatment is the over-the-counter natural hormone called melatonin. Studies have shown that this is effective in reducing the dream acting out in about 68% of patients, which is pretty good, not perfect by any means. And I don't mean that it cures RBD, it simply reduces the movement so they are less violent, they don't disturb the bed partner, and the risk of injury goes way down. But very well tolerated, some morning drowsiness, and in fact, we don't recommend any one type of melatonin, specifically either the long-acting or the short-acting. There's no real evidence that any of these work better than any other one. We started at 3 milligrams, and then increase the dose by 3 milligrams every week or so if the movements are continuing. Most people need 9 to 15 milligrams to see a good response, a fairly high dose. If melatonin is not working and the movements are really violent and disturbing, we may move on to the prescription sedative medication Clonazepam. This is a long-acting sleeping tablet. It's potentially dependence producing, but it's rare that that's a problem. It's very effective, 90%, but there are more side effects. It can cause unsteadiness, and that, of course, is the last thing we want in somebody with MSA. Sometimes some woozy thinking in the morning, daytime sleepiness, and in men, it can sometimes reduce sexual function. Again, something that's the last thing we want to do in at least early MSA. So we are careful about using the medication, but we do when there's a risk of injury. We start at usually 0.5 milligrams, and we may go up as high as 2 milligrams, depending on side effects and on benefit. Again, I have to emphasize that neither of these medications affect the course of the illness. They simply treat the symptoms. And then there's a very interesting report from Mike Howell up in the University of Minnesota, who reported using a customized bed alarm system commercially available, where the bed partner speaks into a microphone and says, "Darling, nothing's wrong. You're not being attacked. Lie down, go back to sleep." And then when there's movement, it triggers that voice. And he reported being effective. I have very little experience with that, but it is certainly something non-medical that could be tried. Well, the other type of movement disorder that we see in multiple system atrophy is something called periodic limb movements of sleep. And that's quite different from RBD. It happens in non-REM sleep as well as REM sleep. And it's very gentle. It's generally just small, regular twitches of one or both legs occurring every 5 to 90 seconds during parts of the night. Can be bigger movements, but generally it's not. These are very common. They occur in perhaps at least 30% of older people who do not have MSA or any other disorder. We see them in Parkinson's disease. We see them in people with sleep apnea. So they're not specific at all to MSA, but they are very common in MSA. Usually they don't arouse the sleeper, and usually they don't need treatment. This is what they look like on a sleep study. You can see here in the leg channel here, these very regular jerks of the legs, quite different from what I showed you before for RBD. And at this particular, these leg jerks in this person are not affecting the person's sleep at all. Well, let's change direction now and talk about breathing. And let's talk about stridor. Stridor is a strained, high-pitched, harsh inspiratory sound different from snoring. This is snoring, but stridor sounds something like this. And it is caused by restriction of airflow through the larynx or the voice box. So here's a diagram of it. Here's our tongue, here's the mouth, and then the airway goes down the neck, of course, and on the top of the neck here is the larynx or voice box. And of course, we can all feel it in our throat, in our neck here. It's the Adam's apple. And if you put your hand over the Adam's apple and talk, as I'm doing now, you can feel the vibrations because much speech is generated through the larynx. And this is what the larynx looks like. If you look down from above onto it, we have these two, shown white here, vocal cords, and they vibrate when we talk. When we breathe in, the vocal cords open. When we breathe out, they start to slowly close. And I've demonstrated that in the next slide. Here in inspiration, when we breathe in, there are muscles which open up those vocal cords called abductor muscles. When we breathe out, they partially close, not completely. And these are the adductor or closing muscles which do it. And that's all normal. Now, what happens in stridor? Well, in stridor, in MSA, we've got, as you remember, problems in the brainstem. And it's there in the brainstem that these muscles of breathing in and breathing out are controlled, and things go wrong. And during breathing in, inspiration, not just the abductor muscles, which open up the vocal cords, contract, but at the same time, wrongly, the adductor muscles, which close the vocal cords, contract, and therefore they narrow the opening, which certainly shouldn't happen. And as air comes in, it makes that stridor noise. Now, that's what happens early in the disorder. Later in the disorder, there's such problems in the brain stem that the nerve cells that control both the adductor and abductor muscles stop functioning altogether, and the vocal cords just sit there, not completely closed, but very narrow, and they don't move in, they don't move out. So here, this illustrates it. Here's earlier in the illness. We're trying to breathe in, so the abductor muscles are trying to open the cord, but the adductor muscles are functioning as well, and the vocal cord becomes partially closed. And then later on, all the muscles are paralyzed, and the cords just sit very narrowly open at the time. Now, I'm going to show you a video now of a patient with MSA and stridor. We recorded this by passing a very narrow tube through the patient's nose and down the throat and positioning it just above the vocal cords with a camera. It was a very small tube used for children generally, though this was an adult, and was comfortable enough that the person was able to fall asleep. So we were able to record stridor during sleep. Here you can see the vocal cords of the person and watch what happens and listen. See that as the person breathes in, the vocal cords paradoxically close and we get the stridor sound. That's not breathing out, that's breathing in. And you can see that this is sometimes distressing to patients, though most of them actually sleep through it and are not aware that they have stridor at all during the night. How common is stridor in MSA? Not as common as RBD, probably 12 to 42% of patients. It's equally present in people who have the Parkinsonian form of MSA or the cerebellar form. There's some evidence that the stridor may be more severe in the Parkinson's form. Initially, it occurs only during sleep, but sometimes later in the disorder, it can occur in wakefulness as well. How do we diagnose it? Well, we take a history from the patient and the bed partner. Often it's the bed partner because, as I say, most of the patients are not aware they're even doing it. And then today, with modern technology, often the patient or their bed partner brings in a home recording of it, and I can listen to it, and yes, that's clearly stridor. If we're unsure, we do polysomnography and listen to the sound during the sleep study. Then the other thing we also do is we look down at the vocal cords during the day while they're awake. This is called laryngoscopy. It's done either by an expert ear, nose, and throat physician, or at Mayo, a lot of it is done by one of our expert speech pathologists who specialize in this area. And when they look down, they may see a number of things. The first thing they may see is normal cord movement. The vocal cords move normally. And that's not to be unexpected because remember, initially it only happens at night during sleep. But even if it's happening only at night at sleep, when they look down at the vocal cords, they may see they're not moving quite normally. They're still moving out on breathing in, but not as much as they should. Or maybe they're already moving in as they breathe in, even though not enough to cause stridor during the day. And then later in the disorder, the cords are completely fixed and they don't move in and out at all with breathing at all. And this is the spectrum from mild stridor to more severe stridor. Usually both sides are affected, but sometimes only one. Is this important? Well, stridor occurring during the day, during wakefulness, is very worrisome. It suggests severe problems with breathing. Stridor at night appears to increase the risk of sudden nocturnal death, especially if the vocal cords are more severely affected. And what we think happens is that just during the night, the cords suddenly pull completely shut and can't open at all, and obviously breathing can't continue. How do we treat stridor? Well, in the majority of patients, we can treat it with continuous positive airway pressure, or CPAP, at night. This is the technique used to treat the much more common obstructive sleep apnea. There's a mask, in this case, just over the nose, in some patients over the nose and mouth, and the machine pushes air in under pressure. It's not oxygen, it's just room air. It's not breathing for the patient is breathing themselves, but the pressure of the air can open up the vocal cords and keep them apart and stop the stridor. And this is very effective in most of our patients if the stridor is only happening during sleep. Of course, if it's happening during the day, that's a different story. And we are a little more concerned if the vocal cords don't move at all. And of course, we want the CPAP to control the stridor. The other approach to treating stridor is to use a tracheostomy, which is a surgical procedure low in the neck where a little tube is placed into the windpipe or trachea and bypasses the vocal cords altogether. We consider tracheostomy if stridor is present during the day, especially if it's causing distress. And sometimes, as you can hear from that sound, if that was happening during wakefulness, that may be very distressing to the patient and making them feel very short of breath. And there's no question we've got to treat that aggressively just to give some relief. We considered if the vocal cords are so severely affected they're not moving at all, or the CPAP doesn't work at all. A tracheostomy is open during sleep and then is closed during the day, so the person can talk normally, swallow normally. But of course, if stridor develops during the day and becomes severe, immediately it's open to give some relief. Tracheostomy will prevent death at night due to stridor, and there is some evidence that it may prolong survival. But regrettably, it does not prevent death from other causes, because there can still be decreased drive to breathe from involvement of the nerve cells in the brainstem and other complications of MSA. When we start talking to a patient about tracheostomy, I'm very aware that this is entirely the decision of the patient. Obviously, the patient wants advice from family and from the physician, but in the end, it has to be the patient who makes a decision whether to do this or not. It's not an easy decision. Tracheostomy, it's a physical surgical procedure. It's also, to a certain extent, an invasion of body image. And we have to think carefully about that. We have to have someone who can take care of the tracheostomy and somebody who's got good hand agility. And if the patient's not got a paired partner who can do that later on in the disorder, that might be very difficult to do. I take very much into account the patient's own philosophy of life and death, of quality of life versus quantity of life. And often we have to think about it carefully, and eventually the patient will make a decision one way or the other. Let's end up by talking briefly about other breathing disorders in MSA, and the first one is obstructive sleep apnea. Now, obstructive sleep apnea is extremely common. It happens especially in older patients, in men more than women, in overweight patients more than underweight patients, but it is very common. And it happens obviously in multiple patients who don't have MSA, but it's also very common in MSA, even if one is not overweight. What happens in obstructive sleep apnea? Well, air comes in through the nose or mouth as we breathe in, goes down the back of the throat, down the windpipe, and into the lungs. Now, during the day, there's no problem. Everything's held open by the muscles of the throat. When we sleep at night, the muscles of the throat relax. Obviously, in REM sleep, they relax a lot, as we talked about, but even in non-REM sleep, they relax. As a result, the tongue here can fall back, the soft palate can fall back, and we can get a partial obstruction here, and the air then vibrates around and causes snoring. However, in some people, that obstruction, as shown in this picture, becomes complete here. No air can get into the lungs. The brain does not like that and responds by immediately waking the person up. The instant they awake, the muscles work again, the throat opens, air gets in again, and they fall asleep again. So we have a constant pattern through the night of stopping breathing, waking up, going back to sleep, stopping, waking up. And that's how obstructive sleep apnea works. It is not as dangerous as stridor. Probably because, for reasons we don't fully understand, patients wake up with the apnea and immediately open up the airway again, whereas with stridor, they tend to sleep through it and don't have that signal to wake up. So this is not dangerous in the sense that people are going to stop breathing permanently during the night, but it can cause sleepiness during the day, push up blood pressures, and have other bad consequences. So we do treat it. The treatment of obstructive sleep apnea is generally the continuous positive airway pressure I talked about earlier. That's what it was invented for. CPAP. Here's again a person wearing it just in his nose. Here's a person wearing it over the nose with a mask, but some of them go over the mouth as well. And as you can see, the positive pressure opens up the airway and the snoring and stopping breathing goes away. There's a less common form of sleep apnea called central sleep apnea, in which the airway is completely open, no problem, but the brain centers of breathing don't send the right messages. So when the person falls asleep, they just stop breathing for a while quietly, wake up and start again. Again, not dangerous in that sense, but very disruptive to sleep and to alertness during the day. And as you might imagine, central sleep apnea does occur in MSA. We treat that very much like obstructive sleep apnea, but with a slightly different machine called a bi-level positive airway pressure machine. And then finally is one of the more serious disorders of breathing called hyperventilation, in which there's just a decreased drive to breathe. One doesn't stop breathing, but those centers in the brain stem which control breathing just reduce the drive to breathe. And that's especially prominent during the night, but eventually can happen during the day. Now, there are rare patients with MSA in which that reduced breathing, the hyperventilation, comes early in the disorder, though most often it's much later if it is going to occur. And we can help those patients even during the day by, again, a tracheostomy and attaching that person this time to a true ventilator, which helps their breathing. But again, all the factors I discussed before under tracheostomy and stridor apply again, and we're very careful in thinking about whether a patient feels it is in their best interest to do that, but that is certainly available. So let me summarize the take-home messages here. Sleep disorders are very common in MSA due to the disorder affecting the brainstem. REM sleep behavior disorder can occur early or late. It can result in injuries, but the good news is it is treatable in the vast majority of patients. Stridor is very specific to MSA. There are not very many disorders which cause stridor. It's due to vocal cord dysfunction. It may be a sign of poor prognosis, but is generally treatable with CPAP or in selected cases, tracheostomy. The other sleep disorders, obstructive sleep apnea, etc., are quite treatable generally as well. So to summarize, common symptoms, but the good news is we can generally help and we can improve quality and sometimes quantity of life in this distressing condition. I hope that's been helpful, and I'm recording this in advance, but on the day of the meeting, I'll hope to be available to answer any questions. So thank you for attending.
Thanks, Dr. Silber. And thank you everybody who's joining us today. My name's Elaine Douglas, and I'm going to be moderating the question and answer portion of this session. So please continue to add your questions to the Q&A box at the bottom of your Zoom screen. So Dr. Silber, there's a question here. Does stridor cause decreased oxygen saturation?
Yes, it does. If you record the oxygen saturation during stridor, during sleep, if it's mild, it's like snoring, it won't. But if it becomes more moderate, there will be drops in oxygen saturation as the amount of air going through those narrowed vocal cords, as it decreases, oxygen will transiently drop, go back to normal again, and then with the next breath, drop again. So it will drop oxygen, and when stridor becomes severe during the day, if it does, which of course is the less likely course of things, it's not inevitable that stridor is going to move into that more serious phase. It doesn't by any means happen to every patient. Then there will be a general drop in oxygen.
Thanks. Another question is, you talked about REM behavior disorder, but can MSA also cause just a lack of REM sleep, where there's no REM sleep at all?
Many neurologic diseases affect eventually the sleep stages. It would be unusual for REM sleep to go away altogether in MSA. It's not one of the disorders where we see that REM sleep vanishing altogether, but there may be a decrease.
Great. So I was wondering about stridor. How many other conditions cause that condition?
Yes, it's a good question. That stridor is relatively specific for MSA in the setting of people with Parkinson's-like disorders. Ordinary Parkinson's disease, the much more common disorder, generally does not cause stridor. There may be occasional exceptions to that, but in general, when we have someone who presents with signs of Parkinson's and they have stridor, almost inevitably that is MSA. There are other structural problems in the throat which can cause stridor, a tumor of the vocal cords and the voice box, and similar conditions, things from outside pushing in on the vocal cords. And there are some other very rare neurologic diseases which may be associated with it. But in the right setting of a disorder that seems like Parkinson's, or for that matter, cerebellar disorders with unsteadiness of gait, once stridor develops, the vast majority of those patients will be developing MSA.
Oh. Interesting. So I have a question. Somebody says, my wife uses Clonazepam very effectively, but recently she's become increasingly drowsy and unresponsive in the mornings. There appears to be a balance between quantity of drug and her functioning during the morning. Is there a rule of thumb on how to control quantity of Clonazepam?
Yes, clonazepam is a long-acting sedative medication and can certainly cause drowsiness in the morning. The higher the dose, the greater the probability of that happening. So it's really a balance between the movements and how disruptive or violent they are and the side effects. Like with any drug, a balance between the beneficial effects and the side effects. So I think one needs to look at what is the goal here. The goal is first to prevent injury. That is the primary goal. We don't want people falling out of bed and hurting themselves. We also don't want people hurting their bed partners. So that's the primary goal. The goal isn't always to stop all movements during sleep. That would be ideal, especially for the bed partner, because the movements aren't necessarily in themselves disruptive to the sleep of the patient. But there are other ways of managing it. Bed partners have moved into a single bed next to the patient. They've put barriers in the bed. I mean, there are lots of mechanical ways that bed partners have tried to help this. So if the dose can be put down low enough so that are no injuries and no violent behaviors, that might be better than having drowsiness during the day. And of course, there are other ways of treating RBD. We mentioned melatonin, and there are some other medications not as effective which have been tried.
Great. Another question. If my husband had a sleep study and there was no mention of stridor, would that mean that he doesn't have stridor at this time? I think I hear those loud pitched noises. He does have a CPAP machine, but isn't currently using it as his was recalled.
Yes. Um, Regrettably, I can't tell you that he doesn't have stridor because it's not mentioned in the report of the sleep study. Many sleep physicians are not really familiar with MSA. I'm sure that's not a surprise to any of the patients or relatives who are listening to this, that many physicians are not really familiar with this disorder. And if the patient went in, the technician would listen and might simply call this snoring. So the fact it's not in the report does not mean that stridor was not heard. If you think stridor is being heard, make a recording of it, discuss it with your sleep physician, let your sleep physician listen to the recording. If stridor is present, you need to discuss with your sleep physician whether to continue CPAP, even though I know that the one type of sleep machine has been recalled and it's going to be a while before replacements are provided. But what we are telling our patients is, well, if you've got mild sleep apnea, yes, just don't use it for now. But if you've got more severe conditions that need treatment, continue using the machine. The risk of in this recall is not all that high, and sometimes the risk of not treating your breathing problems is higher than the theoretical risk that the company is describing with continuing using it. But that decision can only be made by your own personal sleep physician in combination with you.
Great. So one of the things you talked about was the looking at REM behavior disorders early and connecting that to a diagnosis. And the question is, could there come a time when the treatment of REM could actually diminish the chance of it developing into or development of MSA and other conditions?
Yes, this is the real prize. I mean, this is what we really hope one day we'll have available. This is exactly the way we're thinking, because RBD comes often as the first symptom of these degenerative conditions, Parkinson's, dementia with Lewy bodies, and MSA. The goal would be to have medication available that you could start taking as soon as you developed RBD and would prevent or at least delay or at least reduce the risk of developing the other features of the disorder. And that's absolutely the goal of a great deal of research. And I'm confident that with time we'll find such medication, but it's not coming in the next year or so. It's going to take time, but that is the exact goal. Identify the earliest possible features of MSA, have tests available which can say, yes, this is the direction that it's going to go, and intervene right there and then when you've got just the first few symptoms, rather than advancing disease, but that's the future.
That's great. So an opportunity for prevention at some point.
Mhm.
So another one, presently after seeing 4 neurologists at Duke and UNC, they're leaning towards an MSA diagnosis. It was interesting to learn about RBD, as I've been having this for years, for 4 or 5 years, where I sit bolt upright and start yelling, get down, take cover, always trying to be protective. Also, a history of obstructive sleep disorder and presently on a BiPAP, but still with more than 20 events an hour, presently on clonazepam. After adding melatonin, the number of events in RBD have diminished. Concerned, is this pointing more at disturbances like MSA, and also with ataxic gait autonomic disorders? I think there's going to be more there, but.
Right. Well, as I'm sure you can understand, I can't comment on a specific patient's diagnosis. That wouldn't be appropriate without knowing all the details, etc. All I can say is that RBD can lead to either MSA or Parkinson's disease or dementia with Lewy bodies. Autonomic disturbances, as most of you know, are very common in MSA, but can also happen in Parkinson's disease. So autonomic disturbances by themselves don't automatically indicate that this is developing into MSA. It's obstructive sleep apnea, as I mentioned, is common in people who don't have either of these disorders and in both of the disorders. So there's nothing specific about RBD or sleep apnea. It's a question of looking at all the symptoms, all the results of the tests together, how the disease is progressing, and that's the way that an experienced neurologist will say, look, it looks like it's moving towards MSA rather than something else. But that's the best I can do, just in very general terms.
Okay. I wonder if you could talk more about Stridor and speaking difficulties. So people with MSA often have trouble speaking and understanding their speech. Is that related to the vocal cord changes and problems that you see in Stridor?
It could be a component of the speech difficulty, but it's not the primary one. The primary speech difficulties are due, firstly, to whether this is the Parkinsonian form of MSA or the cerebellar form. Both the basal ganglia, which control a lot of movement, and the cerebellum, which controls a lot of movement, are responsible for coordinating speech, just as they're responsible for coordinating movements of the hands and walking. So whether one has the Parkinsonian form or the cerebellar form of MSA, it's going to affect how one articulates, and that involves movements of the lips and the tongue and the soft palate. And generally, it is that combination of muscles which generate the sounds as I'm talking now, which get affected by the central control problems of MSA. Now, the vocal cords could play a role. Vocal cords do play a role in speech, but most commonly it's the involvement of the lips and the tongue and the soft palate, which gives the dysarthria, the slurred speech of MSA.
Okay. Another question. Many antidepressants suppress REM sleep. Do you find antidepressants have an effect on REM behavior disorder?
Yes, this is a paradox. They actually can increase REM sleep behavior disorder. We're not quite sure of the mechanism. We do sometimes see very young people who get REM sleep behavior disorder on antidepressants, and we think maybe in those cases it's not related to a neurodegenerative disorder at all. It's just from the antidepressants, and we stop them. Though in the vast majority of people taking antidepressants, of course, don't get RBD. And when older people get RBD and they're on antidepressants, there's a lot of people on antidepressants. We generally don't say it's the antidepressants. We generally think it's more likely due to a neurologic disease. Maybe the antidepressants have played a role in bringing it out at that time, but it would be rare that it's the only cause of it, though sometimes that might be so. It's a complicated issue. But antidepressants, which you might think would treat this, because as you absolutely correctly say, they suppress REM sleep, actually do the opposite and can actually make it worse. But I would very much caution, if any of the patients here are on antidepressants for depression and have RBD, do not stop your antidepressants, because you may need that very much for your treating your depression. You can talk to your doctors about it. But in general, we say if you need the antidepressant, continue in the antidepressant or treat the RBD with other medications.
So a follow-on question related to clonazepam. My wife has never tried melatonin, as it was stated that it causes drowsiness at night. From what you've said, the effect of clonazepam is more sedative than melatonin. Is that correct?
Yes, in the vast majority of people, that is correct. Obviously, everybody is idiosyncratic in how they respond to drugs, and you might find somebody in whom melatonin is more sedating than clonazepam, but that would be very rare. Clonazepam is far more sedating during the day than melatonin.
Many people with MSA consider the idea of a trach, and I was wondering if you could talk more about the pros and cons, and especially how it affects daily life.
Well, the advantage of a tracheostomy is obviously to stop the stridor. And there are two aspects to stopping the stridor. The first is to avoid distress, a sense of shortness of breath, and just the discomfort of the stridor. That's a very strong reason, especially if the stridor is happening during the day, to treat with a tracheostomy. The second reason to use a tracheostomy in stridor would be if one believes that that can increase the duration of life and reduce the risk of sudden death during sleep, and we think that's probably so. So if CPAP is not working, or one can't tolerate CPAP, and especially if looking down at the vocal cords, they're becoming fixed or moving very little, which seems to be a greater risk than if they're still moving, even if in the wrong directions, one might consider a tracheostomy preventatively for that. The downside is that this is not something to be rushed into. It is an invasive procedure. It's a tube in the neck. It's quite manageable. One plugs it during the day unless one's having stridor. You can talk, you can swallow normally, but it's got to be looked after. I mean, you'd want to avoid infection. It's got to be cleaned. There's a process of changing the tubes. If the person is beginning to have difficulty with use of their hands in MSA, there has to be a partner or somebody available who can manage it and look after the tracheostomy and is willing to do it. And for some people, I mean, I'll be honest, this is an invasion of body image. For some people, it feels that this is just something I don't want to do. It is more invasive to myself, how I see myself, than I want to do. And as I mentioned, again, there's a very philosophic aspect to this. What is my philosophy of life? What is my philosophy of death? Is quantity of life important? And that's just great if it is. But for other people, it will be no, quality of life is more important, and I just don't want to do this. And, you know, there's no right or wrong in it. It's very much one's own thinking, one's own approach to things. And again, I will emphasize that tracheostomy is not going to give one 20 years of life with MSA or 20. It may reduce the risk of sudden death during sleep. We think it does. But it is a progressive disorder with at present no easy treatment to prevent that progression. And eventually there are other reasons why there's a downhill course in this illness. It's not a cure of MSA by any means. So that, just in a few moments, is the sort of things that I talk to patients about and have them think about. But there's no rush generally, unless there's a really severe stridor. And generally there's time for patients and their family to think about it and talk.
Very
I hope that's
important.
helpful, but it really has to be dealt with individually with your own doctors.
No, it's very helpful, and I appreciate your looking at it in the broader picture. So I'm going to go to another question here about trazodone. My husband uses trazodone, but he doesn't have a good night's sleep. In general, would you suggest increasing the dose or trying something different?
Well, again, I can't obviously comment on a specific patient. There are many reasons for poor sleep in MSA, ranging, and we try dissect out why there's poor sleep. Stridor could be one, sleep apnea could be one, acting out dreams, periodic limb movements, rigidity and inability to move at night that causes stiffness and discomfort in muscles, anxiety, depression. So I think we try and sort out a little bit as best we can what's causing the problem. Trazodone is a very effective, well, a partially effective sleeping tablet, and doses can be increased. Again, I don't want to go into specific doses. Other sleeping tablets have downsides. Clonazepam and melatonin are, of course, sleeping tablets as well. So really, it has to be discussed comprehensively by the physician who's looking after your MSA.
So I want to be sure not to ignore the compliments that we're getting in the question and answer box. So a lot of people appreciate that not only how informative it is, but how easy it is to understand, which is not an easy task with these diseases and the conditions. So appreciation for that. Appreciation for the staff at Mayo and the time taken really spending time with people that feels much more than a lot of places. And a lot of appreciation for the information. And let's see. Yeah, so a lot of the repeating of that. Brilliant responses to the question, so that's good.
Well, thank you very much. I appreciate it. And we try and help wherever we can in a very difficult disorder.
It's so important. And here's another one that's popped in. I've seen information that REM sleep behavior disorder can be linked to medications such as beta blockers and antidepressants. Do you think that these cause the RBD or simply unmask a disorder that's already present? And you spoke a little to that.
I did. This is a very complicated, a very insightful question, but a very complicated issue that not every specialist in this area agrees on. My own personal feeling is that in the vast majority of people on antidepressants who get MSA, the antidepressant is unmasking the disorder earlier than it would have happened otherwise and is not specifically causing it. That's not to say that there aren't a small percentage of patients in which antidepressants themselves cause it. You take away the antidepressant, it goes away and will never come back, and they'll never develop a neurologic illness. But I think my own personal reading of the data is that in the majority of cases, the antidepressant is simply unmasking RBD earlier than would otherwise have happened. Beta blockers are controversial. I don't personally think beta blockers cause RBD, but I know there are some reports that they do.
Mm-hmm. So we have just a couple minutes left, and I was wondering if what are some other important issues that you've seen in your work working with MSA patients related to sleep disorders that you'd like to share with us?
Well, I think I've covered most of them in my talk. I suppose I would simply mention that with any serious chronic neurologic illness, anxiety and depression are often parts of the illness and the response to the illness, and insomnia can develop as a result of those. And often we will treat those with cognitive behavioral treatments rather than trying to put more and more medications onto a patient who already is having neurologic problems and trying to avoid side effects wherever possible. So we are conscious of anxiety and depression as issues which affect people with chronic neurologic disease, and sometimes they need treatment. The insomnia part often with cognitive behavioral approaches, sometimes antidepressants and anti-anxiety medications are needed.
Yeah. So there's a reason for those antidepressants and anti-anxiety meds.
Oh yes, I mean not everybody on an antidepressant is taking unnecessary drugs.
Yeah.
But it has to be, like any medication, there has to be a balance between need and side effects. And but yes, so antidepressants are sometimes needed.
Perhaps we can finish this with this last question. Waking early in the morning, 3:30, and in combination with RBD, what what do you think about early rising, the 3:30 wake up?
Well, again, one has to know the person's own sleep pattern, if they've always been an early morning person, but if unexpectedly they're starting to wake in the early hours of the morning, again, one has to ask why. Are there any physical things causing it? But I'll simply say that early morning waking is sometimes an early symptom of depression. Not in everybody, but sometimes is.
Great. Well, I think we are done. Thank you so much, Dr. Silber, for your presentation. And thank you to all the people who joined in with questions to even enhance it more.
It's been a
So
pleasure.
thank
I
you.
hope it's been helpful. Thank you.
Oh, very helpful. Thank you.